Welcome to our new episode of Digital Health Inside Out. To be honest, we haven't done such an episode for a while. I blame all of it on Sergey. Um, because we started this podcast on choosing a specific topic and doing research on that, getting best experts on the pod. And then we kind of switched to interviews. We added a new show, Digital Health Vitals, but we still want to do episodes on specific topics, and this is the one. It's not necessarily directly in health tech, even though there are a lot of things connected to this topic. And today we're going to talk about GLP-1s. I find this podcast as an excuse to learn more about GLP-1s because I never had time just to do research on my own. So this is perfect. And of course, today we have Sergey Polevikov, my co-host traditionally. Hi, Sergey. How are you doing? How's Vilnius?
Really good, thank you. I'm enjoying.
All right. And then I'd like to introduce our today's guest. We have an amazing lineup of experts. First of all, we have Dr. Beverly Chang. Hi, Beverly.
Hi, everyone. Thank you for the invitation.
Of course. Thanks for joining us. We also have Dave Knapp. Hi, Dave.
Hey, Alex, Sergey, thanks for having me on this. I'm excited for the conversation.
Awesome. And last but not least, we have Sean Sullivan. Hi, Sean.
Hi, excited.
You don't have a system that's set up for these companies to succeed.
Did VC Bros destroy digital health?
Healthcare is like 20 years behind.
That's so disrespectful.
Any little error could be catastrophic in medicine. Agents is like the story of 2025.
YouTube.health.
Everybody knows Sergey already, so we're gonna skip you in the session of introductions and let's get directly to Beverly. Beverly, please tell us about yourself.
Hi, everyone. My name is Beverly Chang. I am an endocrinologist at Weill Cornell in New York. I wear a few different hats in education, research. I like to think that I'm a specialist in translating all of the research into real world practical applications. And so I'm really excited to be here with everyone today. Thank you again.
Thank you. Sean, do you want to go next?
Sure. Sean Sullivan, co-founder of some brands in the GLP-1 space, and have been operating in the space for about 3.5 years.
Very cool. And Dave, please tell us about yourself.
Yeah, my name is Dave Knapp. I run a podcast called On the Pen. It is a patient-centric obesity medicine news platform. And I just fancy myself, more than anything, just a huge fan of Dr. Beverly Chang. So I'm excited to be here. I was telling you guys before we jumped on here, I don't think you could have picked someone better for this show because in this space, I've interviewed hundreds of people, medical professionals, patients, industry people. No one has their head around the science and the lived experience better than Dr. Chang. So I'm always super excited to have a conversation with her. And then Sean is an amazing follow on LinkedIn. If you're not following Sean on LinkedIn, that is a educational and entertaining experience all at once. If you follow Sean. So I'm just super excited to be here and build on the conversations that we have every day at OTP.
Incredible. So we called our podcast, and some of you might not even like the name of it, but we called it Outsourcing Willpower to Pharma. And we're going to talk about a few things today, of course, but I want to start with the clinical side of it. Dr. Chang, can you please, for people who, like me, who hear everywhere GLP-1s, hear now Super Bowl ads and many other places, but still don't know what it is, can you explain how actual GLP-1 work?
Absolutely. And I'll say, Alex, I'm an obesity medicine specialist, board certified, in addition to being an endocrinologist. And it is shocking to me that it has taken you guys this long to do a podcast on GLP-1s. I'm actually very impressed because I feel like that's what the entire world, health tech and otherwise, is talking about. The TLDR on GLP-1s is that this is a protein mimic, if I were to use the most kind of colloquial accessible terms. It is a hormone in our body that we make naturally, but what pharma has done was created a medication that activates and increases the activity of that hormone in our body. And it has made a dramatic difference in people's lives, first in people with diabetes, and most prominently in people with obesity. So anyone with an excess weight issue, who have unique food relationships, cravings, food noises is maybe something people have heard about. Taking a GLP-1 medication has really transformed their lives.
Just for me to clarify, if I understand correctly, GLP-1s is a drug that is not working in your gut, but it's working actually in your brain. Is that correct?
Yes, that is such a crucial distinction, actually, because a lot of biotech companies are kind of working from the root of exactly that, of what is obesity as a disease. Is it a gut problem? Is it a brain problem? And it's unique. It's interesting because the GLP-1 medications have taught us, actually, almost in a backwards way, that it is a brain problem. And we know this because we can measure GLP-1 levels in the gut and in our bloodstream. And if you look at people with obesity compared to people without obesity, those actual GLP-1 levels are normal. There's no difference between the two. So we know it's not a quantity issue, it's more like a quality issue, and we're not quite capturing it where it matters, which is in the brain.
And just again to make sure everybody understands, what exactly happens to a patient who is on GLP-1s?
The most common experience is a sense of fullness. Okay, and I kind of want to distinguish this from hunger, because if you talk to people with obesity, many will say that I'm not hungry until I start eating, and then I never feel full. And so the GLP-1s have a little bit of a nuance there where while they can reduce hunger, but they also primarily increase fullness. And that fullness is experienced both in the middle of a meal. You're eating a meal and you're slowly getting fuller throughout the meal, but GLP-1s help you get fuller at a sooner time point. And it also helps people feel full in between meals. So many people start getting hungry around 4 hours after their last meal. GLP-1s may help extend that for individuals. In people with obesity, sometimes they get hungry just 2 hours after they recently ate, and the GLP-1s help them feel a normal interval of time between having meals.
Very interesting. And again, if the higher dose a patient takes, the more this feeling of fullness happens, or how does that work?
There is some dose response to it, yes. So at lower doses, people start to feel that sensation. At higher doses, you have an extreme sense of fullness, and you can even have push that into nausea. Though some of those side effects, which maybe we'll have time to talk about too, those side effects can occur
We
at any
will.
level. So nausea, reflux, diarrhea, all of those side effects can actually occur separately from the actual effect of the medication. And I want to separate those two out because some people can also have zero side effects and just the fullness, and they can still have effective weight loss.
Thank you. Guys, anyone wants to jump on and add anything on the basic level so our audience understands?
Well, I'm just curious about side effects. Like, if
We'll get
is
to
it,
side effects later, Sergey.
oh my
Let's,
God,
let's
I cannot ask about side effects right away. Like, what's your problem, man? But I'm curious, like, if somebody's like on it, you know, does the person have to be on it for a while? Like, if or could it be like period specific
To get side effects or to get the effective weight loss?
to get the effective weight loss so you can stay with that lost weight?
It varies based on my clinical experience, but in research, they've seen weight loss as early as the first month to first 3 months. I give that range because some studies will actually start asking and weighing people at 1 month, and other studies will wait until 3 months and actually report that data out. But I generally give the estimate to my patients about half a pound to a pound per week of weight loss, starting from the very beginning. But I also like to manage expectations and mention that the first couple doses are really intended to be just starter doses. They're not what we call therapeutic doses. In other words, on average, we don't expect these lowest doses to cause weight loss yet, but we use it to give you a slow ramp up to those therapeutic doses. And that's supposed to help mitigate those side effects, improve tolerability, help people get used to the medication.
So after a couple of years paying $300 per month, I run out of money and get off, whatever it is, Wegovy or any GLP-1. So what happens next? Am I screwed, or can I do something to actually continue with this low weight without actually
As
using
far as
GLP-1?
we know, these medications do not have permanent effects on your body, and that's both a good thing and a bad thing, right? But that does mean that whatever you implement with the lifestyle, with the medication alongside of it, that needs to be continued in order to maintain that weight loss. So if you stop a component of that, let's say you are exercising, you're counting calories, you're doing a usual diet alongside the medication, if you change any one of those factors, then you do tend to regain weight. And in the clinical trials, when they did exactly that, they put everyone on the medication, then they randomized them to placebo or to continue the medication. Those who continued the medication, of course, lost additional weight. Those who were randomized to placebo regained their weight. The time frame is interesting, though, because it's when we look at the weight graphs, typically we look at 1 year and then 2 years. And over the first year, everyone's losing weight. And then the second year is when we look at what happens when we take them off the medication. It's not a mirror image. It's not like you lose 30 pounds in 1 year and you regain 30 pounds in the second year. It's much slower, actually, in the regain. The regain might be 30 pounds down, then 10 pounds up over the second year. And we don't know if that is a lasting, what we call longevity effect of the medication, or is it the people's other lifestyle implementations that have kept a lot of that weight off? We just don't know yet.
But I think this is an important question. I want to make sure when you talk to a patient, do you consider this as a forever drug, and tell the patient that you need to take it for basically for a long time or till the rest of their life? Or you say
Yes.
that no, yes?
Yes, I use all of those terms. Sometimes I talk about it as a long-term medication, a long-term relationship, and I make an analogy to any sort of dietary or physical activity regimen. If someone lost a lot of their weight or put their diabetes in remission because of a ketogenic diet, for example, and then you stop that ketogenic diet, then you regain that weight and the diabetes comes back. So in the same way that you implement anything to make a change, typically we have to maintain that. Now, I do liken it to a long-term relationship in the sense that just because we're doing exactly this regimen today, let's say the maximum dose of semaglutide today, that doesn't necessarily mean a maintenance for you is going to be the same. It might be a less frequency dosing, it might be a lower dose. Certainly some of these strategies are off-label. It may depend on other environmental factors. For example, I've had individuals use these medications for 5 years, 7 years now, and now they're retired, and all of the stresses that have previously stimulated hunger or stress eating or cravings have resolved. And in retirement, you have a lot more time dedicated to yourself. You have a lot more time to do more physical activity and mindful eating. And we've actually found we've been able to pull back on those medications. The strategy changes in people's different lives.
I'll just add to what Dr. Chang said there. From the patient perspective, this is a very common question, first of all, almost every podcast that I go on where it's kind of a novel discussion about GLP-1. That's the first question. It's like, do you have to take this forever? And I understand the question and why people ask it. They're expensive medications. You hear a lot of negative headlines about side effects and all that. So I understand the nature of the question. But I would say from the on the pen community, which is a couple 100,000 people that use these medications, for those who have actually seen the benefits of these medications and been able to experience the fact that these things just work, it's not really a matter of, do I have to take this thing for life? It's like, how am I going to make sure I never lose access to this drug? Because it's that powerful and that effective.
Yeah, I'm wondering if this would be a good point to kind of bring up the maintenance doses that people will end up going on, and to Dave, and Dr. Chang's point, very willingly going on maintenance doses. And then, really a big part of the story with GLP-1s that is being told, but, everyone's focus is really on type 2 diabetes and weight loss. But there are a lot of other things that improve in regard to individuals' health. And that has to do, what I found to be more with cytokine disruption throughout the body, and essentially helping the body not be in such a, intense state of chronic inflammation. Like, we're all walking around every day with inflammation throughout our body at a cellular level, right? Like throughout our entire body. There's overwhelming data that shows that, these medications ultimately reduce inflammation, and that helps the body and organs within it operate more normally. That's why you see like liver enzyme data, core liver function improves, core kidney function improves. That there's an argument that one of the reasons that Pfizer was willing to pay $20 billion for Metsera, which has a pipeline of GLP-1 peptide drugs, is because prior to that they had acquired a company that makes cancer treatment that you can't go on if your liver is toxic. So in the future we may see these GLP-1s thought of as not just a tool for weight loss and preventing or getting individuals into remission from type 2 diabetes, but used as a tool to help regulate core function within the body, because it's reducing inflammation again throughout the entire body. There's actually two doctors that have a dermatology practice that have a video where they talk about they're kind of asking each other, why is it that when we put a patient on Lilly's GLP-1 for eczema, we find that their eczema starts to actually subside before they lose any meaningful weight? Why does that occur? And then they kind of unpack, well, it has to do with cytokines or cytokines, the potato, I guess, however you pronounce it. But that I think this would be an interesting part of the conversation for us to have, because I think it touches on not just this core concept of, is this a forever drug? Should it be a forever drug? And what does that look like? And also, I think to Dave's point, there are lots of people who they don't think about this through the lens of, I don't want to be on this drug. They want to ensure that they're going to be able to have access, because it's not just the weight loss. It's all of these other things that have come along with it that have had positive health outcomes. And, it's very obvious. And I think that's a lot of what is underreported by mainstream media, that this isn't a common thing that gets out. You have to kind of dig to find this. I had to dig to find, these two doctors who not only are doing this in their practice, but they're running a clinical for Eli Lilly. So that's like the other thing that's sort of an exclamation point there, is you have these doctors who are running this clinical practice, but then also running clinical trials for Eli Lilly. Anyway, let me stop there.
I think what you're saying is it's so true, and it resonates throughout the community that I lead as well. When we talk about on our podcast some of the future medications, or even the ones that I get most excited about as a type 2 diabetic or somebody who struggles with obesity, are treatments that sort of get at the underlying biology and sort of treat the underlying biology rather than sort of masking a problem. When we talk about things like Fractal Health, for example, is working on basically a duodenal duodenum mucosal resurfacing, but where they go in, it's the first part sort of after your stomach, before your intestines, and they go in and they just do kind of like I just call it like a face peel, but for the top layer of your duodenum that resets the cells, right? And those are the sensing cells that sense the nutrients that you eat and set off. Dr. Chang could speak way better to this, but set off a whole cascade of hormonal responses in the body, including these nutrient stimulated hormones that these drugs we're talking about today mimic. Now, when we talk about that, patients who have this procedure after losing weight with a GLP-1 are able to maintain it better. That's what the early data is showing in this. But all the patients in my community say, yeah, but what about the inflammation? So I go off my GLP-1, I go off tirzepatide, I get this procedure, but I still want the tirzepatide because it's doing all these other things. And so when to kind of bring it back to my original point, people don't want to go off these medications. By and large, that's the experience in our community. They don't want to go off them.
If I can add a little bit more scientific color here, starting with an analogy, I talk to a lot of my patients on what that long-term and what weight management looks like right now. And the analogy is like driving a car. And if you want to go from 0 to 60, you have to push on the gas. Okay? That's all of our lifestyle, our behavioral modifications, medications, surgery, what have you. But if you want to stay at 60 miles per hour, you have to keep your foot on the gas. Right? So you have to maintain and continue doing what you're doing, whatever you did to get there. But the question nowadays by patients, by us, from biotech, everyone, is, well, where's that cruise control button? Where can I push a button on my car, lift my foot off the pedal so I don't have to be exerting myself so strongly all the time forever, and there's something else that will just hold me there? And I think different biotech companies are coming at this from different directions. What is the cruise control button? It could either be less frequent dosing. Maybe we're injecting every 3 months, every 6 months, once a year. We've heard of the term quote unquote obesity vaccine as a once a year option for some individuals, whereas others are also exploring it from the direction that Sean and Dave have mentioned in terms of inflammation and targeting the underlying cause. We typically call those disease modifying medications. So it's not just a band-aid. It's not just something that reduces appetite or causes weight loss. It's something that adds to the root cause of what we think is the cause of obesity, whether that's increased hunger, lack of fullness, inflammation in the areas of the brain that control our body weight set point. It might actually be even duodenal resurfacing, what Dave mentioned as this facial peel of your duodenum may be disease modifying if it changes our microbiome, and we think if our microbiome is the cause of obesity. So we're exploring a lot of what might actually be disease modifying, and the best way to know whether it is if you stop the medication, right, and it fixed the underlying problem and you don't need the medication anymore. Right now, the GLP-1s and most of the medications we have, we would say perhaps are partially disease modifying, and that's why we see weight regain at a much slower rate, perhaps in the second year of these clinical trials, that there might be something that address the root cause there with the GLP-1, even though it also suppresses appetite and controls cravings.
You brought so many important points. I have like 17 follow-ups already. Don't know where to start. Interesting. I just want to hear from you guys because this is the first time when we talk about a specific drug, and there are so many like new studies come out like every day, and like somebody says, "Hey, this is going to help with addiction problem from alcohol, for example." So not even related to obesity. What is it? Well, first of all, is it true, or maybe I wasn't paying attention that this is like the first drug that we're still like exploring and doing a lot of research like on the fly, wondering what else this thing can help us with, or and then at which point we find out like, hey, these are all the capabilities of GLP-1s.
I think there's a lot there, and a lot of it is reactive, right? A lot of that is recognizing the pleiotropic effects of GLP-1s, how, like Sean said, the overwhelming evidence that GLP-1s reduce inflammation, and recognizing that so many of our named diseases today have a root cause of inflammation. So whether that's even addiction, alcohol use, eczema, other rheumatologic diseases, studies in psoriasis, psoriatic arthritis in combination with other disease-modifying agents, whatever it may be, we're exploring it. And I think it's also because we're recognizing that some of these diseases that we might consider mental, like alcohol use, may also have its roots in the brain, that there's an inflammatory reaction going on in the brain. And if I were to really go deep into that for your listeners, you have to think about the brain as our master control system for our body, right? And in the brain, there's a region called the hypothalamus that controls all of the homeostatic functions. That's our body temperature set at 98.6. That's our circadian rhythm, and that's also our body weight. And all of those are set on a thermostat, effectively. But if we are exposed to what we call an obesogenic environment, a stress-inducing environment, or an inflammatory environment, we have seen changes in the brain such that you have fewer neurons that are supposed to be controlling appetite. And that changes our set point, our relationship to food, so that eventually it also changes and increases our body weight set point. And what we found was that just losing weight doesn't actually fix that. It fixes some of it. If we change people from a high-fat diet to a low-fat diet, some of that inflammation goes away, but those neurons that are intended to control appetite don't grow back. And so I think that's one of the really root causes of why we see the increase in the obesity epidemic and an increase in severe obesity in particular, and why people find it so hard to lose and maintain their weight.
Yeah, that was excellent, and I think it's great to hear the hypothalamus come up in this conversation because it never does. But that's such an important key thing, and I think people really should research that more closely and understand the really important role that the hypothalamus plays in like literally controlling everything. Our subconscious thought is controlled by the hypothalamus. So I thank you for bringing that up because I think that's a really important detail for certain.
I think to Dr. Chang's point about this being sort of reactive, I think it is important that there's sort of a debate that goes on sort of in the outside world. People that discuss these medications who don't eat, breathe, and sleep this stuff like we do. And that is this idea that these medications are new and there's not a lot we know about them. And it's kind of true and kind of false at the same time. So we have like 20 plus years of data on this specific hormone, GLP-1, which is, what we're talking about today is just, we tend to call them all GLP-1s. But the newer class of medications work on two hormones. In the second, and the one that tirzepatide, Zepbound, Mounjaro primarily work on is called GIP. And as we were talking about earlier, our endogenous nutrient-stimulated versions of these that our body makes in response to eating food, they last a very short time in the body. And so, as Dr. Chang laid out earlier, Pharma found a way to make these last much longer. So they're penetrating areas of the body for much longer, binding to these receptors for much longer than you're ever going to get with your endogenous GLP-1s. That's why if you see something like a supplement that increases your natural GLP-1 or it's nature's Ozempic and it's going to make your body create more of these nutrient-stimulated hormones, I mean, the reality is eating a Cheeto is going to increase your nutrient-stimulated hormones because they're just that. They're nutrient-stimulated hormones. But they're not going to last in the body because they're broken down very fast. What we do not have as much data on is especially this GIP hormone, how deeply it's penetrating into the brain, how long it's staying there, and what that's doing in the brain. And we're just starting to unpack that, right? Because this drug has only been on the market for, 3 years, Dr. Tchang, maybe? Mounjaro? Yeah, so it hasn't been out for that long versus, GLP-1 analogs. We go multiple generations. You have Ozempic, you have Trulicity, you have Saxenda, Victoza, and Byetta, which was the first. And so GLP-1 agonism is sort of well studied. GIP not so much. And the interesting thing is when you look at, as you said, Alex, the future of GLP-1 GIP, if you just look at Eli Lilly, for example, they have a drug in study called brenipatide. And if you look at the studies that they're running, these clinical trials, it is alcohol cessation, opioid use disorder, asthma, bipolar. And so you're talking about neurological processes that these long-acting hormones are interrupting. And so I do believe that in a sense it's reactive. I mean, perhaps the scientists there at Lilly always knew someday these are going to be used for this. I think one of the interesting conversations that we've been having over at On the Pen recently is just this idea that these drugs are often referred to by the CEO of Eli Lilly. His name's Dave Ricks. You can ask Sean. He knows a lot about Dave Ricks. He refers to these medications as anti-hedonic medications. And so there's a lot of folks who experience, with tirzepatide especially, it seems like, this phenomenon called anhedonia, sort of this flatlining of emotions. And so I think it's important when we discuss the topic of, how do these work in the brain? I think it's important to identify that there's a lot that we still don't know. As much of a cheerleader as I am for these medications, as much as they're changing the game and the landscape of obesity in the United States and really globally, right? I think it's an important conversation to step back and say there are some things that we don't know about these drugs, and they're going to get to the bottom of it eventually. But it's definitely this anhedonia is definitely, I think, something that has to be considered when we talk about maybe some of the negative effects of these medications as well.
Sergey, I guess if Dave mentioned negative effects, your question about side effects is right now would be the perfect time to ask.
I'm not going to ask, no.
All right. I'll ask. Let's talk for just a few minutes about side effects. And Dave, in one of your previous responses, you mentioned that people don't really want to get off the drugs, but the statistics says that 30 to 50% of patients stop within the first year. So 25 to 30% quit within 3 months, and then around 50 to 60% quit by 12 months. So it's kind of question in two parts. One, tell us a bit about my side effects, and two, why such a high percentage of people still drop off the drug?
I think it's an excellent question, and I think it's a great question for somebody who leads a community of people actually on these medications, because there's a lot in them. I've been to some of the medical conferences around obesity medicine, and it seems like, from a clinical side, everybody's scratching their heads and they're going tolerability. And I think that's an example. So when you talk about this class of medications, obviously, these are hormones that are nutrient stimulated in response to eating. So it has to do with digestion, right? And so there's a lot of things that these medications are doing, like slowing down the rate at which you digest food. And so you have all sorts of, sort of GI side effects are very common throughout the entire class of medications. The most common thing probably next to nausea, right? Just that kind of nauseous feeling. A lot of times these are, when these are compounded, they're compounded with something that can help you with that nausea. And so I think those are sort of the big ones, but I think what's underestimated, and you guys can chime in on this, but I think what's underestimated is how much a patient is willing to tolerate those things if it means it's going to actually work in terms of actually helping somebody to lose weight. I've actually said this before. I don't have very many side effects. I've definitely experienced the anhedonia at the higher levels of these of tirzepatide, but I've never really had the nausea. I've never had the real slowing of the gastric emptying or the constipation or the diarrhea. I've never had any of that issue with these medications, but I would gladly trade off and have nausea if it meant that I was going to be a better responder to these medications. I would deal with being nauseous all day if it meant that I could get my weight down by taking a shot. Unfortunately, it's not that easy for me. I think across the community, the biggest reason for that number is twofold. One, it's that folks are often given a prescription for these medications and then they're never given any sort of follow-up. It's sort of like a prescription is written. Here's a fun anecdote. I've heard many times from patients within the On the Pen community who have said, I got a prescription for this medication and I didn't even realize it was a shot until I got it filled at the pharmacy. So that's the level of one end of the spectrum of the level of care that's out there, right? So then with titration and dosing frequency and supplementation that could help people manage these side effects, there's nothing there, which is why things like On the Pen have done so well, right? Because we have a community of people who can kind of feed off of each other in a sense. I think the other part is access. I mean, it really, a lot of the numbers that we see today that people like to quote in terms of people getting off these medications, I think is tainted by the fact that very early on, the pharmaceutical companies completely miscalculated how big these drugs were going to be, how willing people would be to pay for these medications, right? Because the biggest risk for Novo Nordisk in bringing the drug to market is that payers, insurance companies, would never go for it. And so there was an underestimation of what people would be willing to pay out of pocket for something that actually worked. And these drugs were in shortage and they caused all sorts of havoc. For somebody like me, for example, when I was first prescribed Mounjaro, there was a $25 manufacturer savings card that had no stipulations to it. So you could get a savings card from Eli Lilly, and regardless of the list price, which I think was probably $1,100 or $1,200 at the time, you could, even without diabetes, go pick it up at the pharmacy for $25. And so it gave a lot of people sort of a taste of this medication. It immediately went into shortage. There wasn't enough to keep on the shelves, so to speak. I had to skip a lot of two of the middle doses of the titration process altogether because they just were not to be found anywhere. And so I also missed the weight loss that would have come with spending time on those lower doses. I think a lot of doctors also follow the clinical trial dosing protocols, which were not designed for an individual patient. They were designed for the masses. And often, my knock on a lot of the clinical trials is they're designed for Wall Street anyway. They're trying to get a number, X amount of weight loss in X amount of weeks. And it's always the faster, the better. And so a lot of times especially these phase 2 trials you're slamming people with very high doses of these medications when for most people, I think what we're going to find in hindsight, and I'd love to hear Dr. Chang's opinion on this and what Sean has seen in his businesses, but I really think what we're going to find in the long term is that really slow titration, even these incremental doses are too big of a jump for a lot of people. And I think if that can be addressed and we can start treating the patient as an individual rather than trying to throw them into this, clinical trial box, I think that a lot more people will stay on the medication from a side effect standpoint. But I think those numbers are wildly tainted by people's inability to access them early on.
It really reminds me, I've done a lot of work many years ago in HIV/AIDS space. And when patients in my country in Ukraine started getting ARV, antiretroviral therapy, there were so many side effects, but doctors were telling them, it's a life-saving drug. Like your viral load is going to go down if you take it as prescribed, no matter what. So my question to you, Dr. Chan, would you recommend your patients to push this through and wait till the side effects go away, but still stay on the drug, or no?
I love that you brought that example because I think that in weight management, it's that, but flipped. It's the patients who are coming in saying, I'm willing to handle XYZ, make me nauseous. I want to be nauseous, right? In order to get the effect that I want, to get that weight loss. And what distinguishes obesity as a disease from everything else in the medical community is that it hasn't really been a medical disease for more than 30 years. So people are used to figuring it out themselves, doing it without medical or professional guidance, doing it without any understanding of the science, just taking in whatever marketing they're receiving and friend recommendations and trying everything, using their own bodies as their individual experiments. So their risk tolerability, these patients' risk tolerability is so much higher than what you would see in any other disease. And I would liken it closest to someone with cancer. Someone with cancer has a different level of risk tolerability than someone who has high blood pressure or high cholesterol, these things that you don't feel, these things that don't necessarily have a death sentence. But when it comes to obesity, people feel like they've been living with a death sentence for all of their lives. They've never had a treatment for it before. Now that there is having some effect, they're willing to tolerate a lot. And to Dave's point, I think we all, whoever we are, whether we're pharmaceutical companies, biotech, health tech, we have to be mindful of what patients are willing to endure to get access to that life-saving treatment, because ignoring that piece really means that we're taking advantage of their risk tolerability. I do also want to just reinforce Dave's point about access, because the numbers you quote about 50% discontinuation within 1 year is something that I hear very commonly. Academic circles, research circles quote it as well. It first came out of a white paper from Blue Cross Blue Shield, the insurance company who was supposed to be paying for access to these medications. And it was like 2 pages long. There was very little detail in why people were discontinuing at a 50% rate. Subsequently, we have an academic paper, more objective, from Cleveland Clinic, citing that half of those discontinuation rates are due to cost or insurance issues. So we forget, I think, that with these white papers and these headlines, that the reason for that 50% discontinuation is intentional and designed by these payers who have a different call to action, right? Their goal is not health preservation. It's not disease treatment. Their mission is just healthcare affordability. And so they have designed a system around all of this so that they can target at least a 50% discontinuation rate. And so we have to think again from that patient perspective that Dave so well vocalized here, that what patients want is access to these medications. There was a time when there was a GLP-1 shortage and people couldn't get their semaglutide or their tirzepatide. Actually, it was mostly semaglutide at that time. And the ways that they were troubleshooting for themselves was so creative. It was, can we send a prescription to these 3 pharmacies? This pharmacy, I'm visiting my aunt in Texas in a week. Can you send it over there? I'll pick it up there so that I don't miss out. I have 4 pens left. I'm going to ration them for the next 6 weeks so that I don't fully run out. And they are desperate to stay on the medication because when it works, they choose to stay on it lifelong.
Yeah, I can say definitively that if it is accessible and affordable, they stay on. So I operate 3 different brands in the space. All of them have been leading in regard to being, if not the lowest cost, near lowest cost provider. And, in the last few weeks, there's been a lot that's sort of been talked about and exposed as a result of like one company in the space getting a lot of publicity. This company called MedV, and there were subsequent articles and sort of like pulling back the curtain a little bit. One of the things that's sort of come out is that there are, you know, high churn. The customers are bouncing around from like one brand to another. Well, that's because almost all of these companies operate with a model where you sign up in your first month, it's X price. And to be honest, to be totally fair, Lilly and Novo do this exact same thing. They have starter prices basically. Once you get past the starter price, then they just go and jump ship to the other brand to get that starter price again. So this is all on the compounding side primarily, but this same thing occurs with the brand medication where people can't afford it beyond that starter price. And now, you know, they're going to start to jump around and that creates disruption. So my companies have just had flat rate pricing, no step up, no step down. It's just the same from the beginning. Our retention rates are above 80%, which no one has in the space. And you know, our first year member churn is ridiculous. It's over 90%. So if you make it accessible and affordable, people don't leave. They don't go off the medication. And what you do end up seeing is they titrate down. They have, you know, their sort of peak weight loss, and then they titrate down to a lower dosage to basically maintain. And it's all of these other things outside of just the core weight loss, I think, that end up, you know, helping keep people along.
Sean, for our audience, can you explain compounded drugs versus branded drugs?
The compounded version. So yeah, an analogy that I like to use, which isn't accurate, but it's a fun analogy, I think, is basically if you took, conceptually, if you take a compounded drug that's compounded by one of the, you know, 503A or 503B compounding pharmacies, and you got into a time machine and went 7 years into the future, that same drug could then be eligible to be a generic because a patent will have expired in the United States, which then allows that same core drug to now qualify as being a generic. So it's like a bad analogy, but basically compounding pharmacies are allowed to create a near duplicate or a duplicate of a drug if there is a shortage of the primary brand drug, right? So that's the core definition of why they exist and what they're allowed to do. Fast forward to, you know, and then Dave, I'd love to hand it off to you, but then fast forward to where we are today, and now you have, you know, compounding pharmacies that are creating the duplicate, but they're also finding that patients have better, this is something that Dave mentioned earlier, when you add a specific vitamin to it, it helps reduce the amount of nausea that a patient will have. So now you have compounding pharmacies that are, again, creating that duplicate drug, adding, you know, a specific vitamin to it, and now that is a new formulation of that same core drug.
I think if you have no idea how our system works, and you're just like, what is this concept of compounds? You just know that drugs are very expensive in the United States, and you know that a bunch of people are getting them cheap. How are they getting them cheap? So that's like the compounding market has afforded that, and I think that at first they were really a backstop in what they were designed to be, a backstop to our pharmaceutical manufacturing system when we do not have pharmaceutical companies that can keep up with the demand of a drug or the need for a drug. I mean, it could be a national security thing, right? We want a thriving industry that can make drugs that don't require the United States to be reliant on wholly on overseas manufacturing. So you have you have the exact copies that can be made in times of shortages. Those shortages are over. And now there's another carve out within this law, this Food, Drug, and Cosmetic Act, that establishes the ability to compound, where compounders can offer this same branded medication that's under patent as long as the patient has a need, for a version of it that is not available in the commercial version. So either a different presentation. For a while, there was just the pens. And so if a patient, for whatever reason, needed an incremental dose, they could get a vial of it from a compounder. Because they can draw it up with a syringe instead of getting a fixed dose, or if they had some sort of side effect that made the drug intolerable, like nausea or something. It's never been done on that type of compounding. That's the latter has never been done on the scale that we're seeing with GLP-1. So it's sort of a new thing, and it's sort of a contentious topic within the industry, between the industries, the pharmaceutical industry and the compounding industry. But it's provided patients access and brought about a level of competition to exorbitant drug prices in this country that we've never seen before. And it's also, I believe, forced the pharmaceutical companies to look at it different. And that's why you see both Eli Lilly and Novo Nordisk sort of leading the way, especially Lilly, with a direct-to-consumer offering that sort of skirts around the entire healthcare system, the entire insurance system here, and goes direct to the consumer and says, you can pay this amount of dollars for our medication for cash. And we'll forget the insurance companies, forget everything. And that was the compounding telehealth model that Big Pharma is now copying and offering to patients, something that never existed before this competition that pharmaceutical companies had with compounds.
Quick question. Do we have a shortage now? I know we had a shortage a year ago for sure, but do we have a shortage now?
We do not have a shortage now. And I just want to add a little bit, like a subheading to that compounding piece, because for me, it's a huge question of safety for my patients. From an official standpoint, all of the professional scientific societies have come out against compounding. The organizations that I belong to, the Obesity Society, American Board of Obesity Medicine, Endocrine Society, all of these organizations have come out explicitly recommending to patients to avoid compounded medications or compounded GLP-1s specifically. There are areas that Dave mentioned in terms of personalization. We compound, antibiotics with an orange flavor or grape flavor for our kids. And so there are areas where everyone's very comfortable with that. But when we're looking at the mass market of GLP-1s, the main issue is that you just have a wide, very, very wide spectrum of quality and safety. I've used the analogy before of wanting a Chanel bag, something that's a luxury. And what I get instead is a bootlegged dupe from Chinatown that looks like a Chanel bag, but it frays at the ends. It doesn't last as long. Maybe I go back and get it fixed, and then I get something that's just not as good as the first time they ordered it. And from the experience of some of my patients who have done compounded GLP-1s, they notice that the first month it works really well. The second month or third month, they're on the same dose, or maybe they're on a higher dose, and it seems it's suspiciously maybe diluted, right? And we just don't have any transparency into the quality of that. It's less regulated. So I think a more accurate analogy now is if you're going to take Tylenol, right? Typically you buy it from a pharmacy or you get it prescribed or what have you. Or if you want to get it compounded from your dermatologist, you could do that too. But people don't see that feels like a weird disconnect. And yet that's something that we're applying to the GLP-1 market. I've written extensively about compounding. I'm neither for nor against it. I see both sides of the argument. To Dave's point, the pharmaceutical companies have needed to drastically reinvigorate their understanding of compounding. At some point, they were telling regulators that mass compounding of GLP-1s is an antithesis to personalization, which is one of the laws by which compounding can occur for patented medications. And that doesn't make sense. In fact, the goal should be personalization on a mass GLP-1 market. We should be able to do that. And maybe health tech should be able to help us do that. But pharmaceutical companies initially were not coming at it from the right perspective.
I just want to really wrap up the side effects real fast before we move on to the market discussion. There are a lot of videos, information about this side effect as a muscle loss on the internet, and I want to talk about this for a second because people are asking about it, and there are tons of stories. Like there's a 60 years old woman who got on the GLP-1s and then she stopped, but she already lost a lot of muscle weight and bone weight, and now at the age of 60, it's almost impossible to regain that muscle weight. So, Dr. Chan, tell us what do you think about this side effect when we talk about GLP-1s?
Yeah, the side effect is a great question. And to Sean's point, I think some compounders are thinking about this in a nuanced way of can we add an agent to improve a side effect, whether it's nausea or muscle mass. The issue is that we need clinical trials to prove that, right? Some places can market that a B12 injection or compounded alongside a medication can be helpful, but there's no proof. And in fact, there's no proof of safety either. So adding something can also make it challenging for the medication to work effectively. It may stimulate the immune system more, or it may increase the risk of what we call neutralizing antibodies that reduces your own effect or the effect of your own GLP-1 production. And so when we think about side effects of muscle mass, a lot of biotech companies are double clicking on that too to figure out, can we iterate on the GLP-1s, add something else to improve body composition? Because when we think about obesity, it's actually not weight loss that people want, it's fat loss specifically. So can we have a third or fourth generation of GLP-1s plus that target only fat mass and not muscle mass loss? I think the biotech companies are a little bit ahead of themselves, which may be exactly what they're meant to do. But the two caveats to that is, number one, all the data we have is limited to fat-free mass or lean mass, which are nuances in terms of nomenclature that do not equate to muscle mass. Fat-free mass includes bone. You mentioned that too in your 68-year-old woman, that she had bone loss. So we don't have enough insight into what the bone loss might be. Lean mass includes organ, like heart. And we actually have data demonstrating that in some populations, it's a good thing to lose some heart muscle. Because when you have something like heart failure with preserved ejection fraction, that's a disease of too much heart muscle, and we need to reduce that. And when you look at the trials that are exploring a GLP-1 plus bimagrumab or enobosarm or some other agent that increases or preserves muscle mass, you have to ask, what are the side effects of that? Is it preserving skeletal muscle mass, which is what I think we typically all want? Is it increasing heart muscle mass, which is not something we want? Is it increasing vascular muscles, the little tiny muscles inside all of our blood vessels? Maybe we want that, maybe we don't want that, we don't know. Some of those studies, like with bimagrumab, increased our cholesterol levels, LDL, and we also don't want that. So I think biotech is doing the right thing in exploring what is the next generation of obesity medications, but some of that concern is not yet founded because we also care about that composition, right? Is it organ tissue, is it bone, or is it muscle, and what type of muscle? And we also care about the function of that. If that 68-year-old woman is now doing more, lifting groceries up 3 flights of stairs despite less muscle, I am less concerned.
Thank you so much for that clarification. Dave, you talked a lot about access. So the question to you, if a person right now is considering, I need to do research and I'd like to get on GLP-1s, what are the options? Just to buy it on Hims or Row, or maybe my insurance would cover it? What should people know about the access right now?
Yeah, I think it's important to understand how to navigate a environment where the marketing around these molecules can be very confusing and very deceiving. And I think that's sort of one of the knocks against the compounding. As Dr. Chang was saying, there's just a very wide. I always struggle with I need somebody to phrase this better than I do, but there's just a wide capacity within compounding to have a really good compounded product or a really poorly compounded product, because there are good and bad actors in every space. And I think the same could be said for big pharma, not to pontificate, but not all pharmaceutical companies are created equal, and not all compounding pharmacies and telehealth companies are created equal. And then there's a third element to this, and that's, so we talked about the pharmaceutical grade GLP-1s from Eli Lilly or Novo Nordisk. We talked about compounding, which is within a regulatory framework. It's different. So 503Bs can mass produce copies in shortage, and 503As can produce these, custom doses and custom formulations when there's no shortage. And those happen under the Food, Drug, and Cosmetic Act. 503Bs have FDA oversight via something called the Current Goods and Manufacturing Process. And then 503As are governed by their state pharmacy boards. So 503A pharmacies, you've got a very kind of wide variety of oversight, right? Because in the United States, from state to state, you might have different regulators, different regulations, funded differently, different capacity to inspect, et cetera. And so there's just a lot of nuance in the compounding world, but there is regulation. Then there's this third one that happens entirely outside of regulation, and we refer to it often as the gray market. But these are Chinese or Indian made peptides often that are manufactured and often imported into the United States illicitly within different packaged as something that it's not to get in the United States. And these are sold online, often with cryptocurrency, because a lot of the payment processors have been shut down. And this is outside of any regulatory framework at all. And folks are getting these versions of GLP-1s, including versions of these drugs that have not yet been FDA approved and finished clinical trials. They're getting them without a doctor's prescription, but with a certificate of analysis or authenticity from one of these online vendors, and they're getting it shipped into the United States with dog food, and eventually it makes its way to their mailbox, and they reconstitute a powder at home. And so you can see from that option all the way to the pharmaceutical option, and people are getting advertisements for all of them. And it's very hard, I think, for the average consumer to understand the difference. And so I think the most important thing that folks can do immediately is understand the difference. If you're purchasing something online without a doctor's prescription, and it is being sold to you as a lyophilized powder that you have to reconstitute at home, just know that you are taking a massive risk with your health. I think, and I struggle with this topic, the gray market, sort of the same way that Dr. Chang, I think, probably wrestles with the compound topic, right? When you have a platform and people listen to you, it's hard to navigate these conversations tactfully sometimes, because folks who, it's on the one hand, Dr. Chang's concerns about, and my concerns about the wide variety of compounding options that are out there are well noted, but it's hard to ignore the millions of people who have used them with a great deal of success. And the same goes for folks on the research grade versions. There are thousands of people within my own community who say, hey, I just got sick of all the rigmarole with my doctor. I got sick of all the rigmarole with the insurance companies, and I'm just buying it straight from China, and I'm down 50 pounds. They don't know all the long-term risks that they're exposing them to. But as Dr. Chang said, the capacity for somebody with obesity to take risk, to treat their disease, to get their weight down is massive. I mean, the tolerability factor is very high with these medications. So understanding the difference and staying within an option that has regulatory oversight. And if you're using a compounded version, there is regulatory oversight. There is a doctor prescription. If you're using the branded medication, the same can be said. I think for those patients, then it comes down to tolerability. Can you tolerate the branded medication? Can you afford it? Do you have coverage? And each individual has to make their own decision. But it is a very nuanced It's a very nuanced topic that requires a high level of understanding. So make sure that you're doing your research before you pull the trigger and hit buy online.
Yeah, I would agree that the gray market is terrifying in regard to the safety of 503A and 503B facilities. I'm sure that there are some, less than ethical operators or people that are not as focused on safety. I haven't met them. I don't know them. The companies that we work with have invested some hundreds of millions of dollars, some tens or millions of dollars into setting up their facilities to manufacture in a truly sterile environment. They have to, what I would tell you is if there was a big safety issue that had occurred and there was actual patient harm, believe me, Eli Lilly would be presenting that front and center every press conference they have. They could be announcing a new Pepsi machine, and they would take time to remind everyone of, hey, remember what happened? So the idea that like there's some huge safety risk is just not. It's possible, just like it's possible that Novo Nordisk's facility was inspected 3 different occasions, I believed, and failed inspection on 3 different occasions. On one of those inspections, they literally found cat hair contamination in or around finished product. That's something that no 503A or 503B I ever work with will have an issue of. They're not going to have cat hair or contamination like that. These are very...
I did hear, Sean, that Novo Nordisk did end their Bring Your Cat to Work Day after that. So hopefully that resolves that issue.
Just dogs now, just short-haired dogs or doodles, because they're
hypoallergenic.
Exactly. Dave also mentioned national security earlier, and I think it's really important that we understand. So in context of demand, let's say tomorrow, because I think, Dr. Tchang touched on the insurance system and what happens when the insurance system gets in the way of access, right? But let's just theoretically say, okay, tomorrow, 30 million Americans now have a script for a GLP-1. Neither Novo or Lilly, or the two of them combined, could meet demand for 30 million Americans who want to go on this drug starting tomorrow. So if and when that happens, guess what? We're right back to that exact same situation as before, where now there is an official short status, and the 503Bs, which are the bulk manufacturers, can go right back to producing as much of it as they want. So, and the other thing I'll mention in regard to that is David Ricks sort of famously went around and did a big press tour talking to investors at different events where he describes the effort that Lilly took to ensure that they didn't have another short situation. So this is a manufacturer of a drug describing how they're actually manipulating the ebb and flow of the supply and demand in coordination with doctors. David Ricks is literally quoted as saying, I think he called it not monitoring, but metering demand, so that there were less new prescriptions being written, and they were just sort of filling demand that had already existed. Right now, this is about 2 years ago when he was quoted saying that. But let's unpack what that means. You have part of the machine that is just continually trying to find ways to ensure that they're operating a duopoly. Or preferably monopoly, which now takes me to, Dave, let's talk about what Eli Lilly is trying to do with retatrutide and trying to get, what is so retatrutide is their new drug that's going to come out. They want to not only ensure that they are the only company that will be able to sell that drug, but they want to prevent it from having eligibility from being compounded by having it classified as a biologic. So this is an example of Eli Lilly wanting to, change the rules of the game so that they can have a monopoly on what looks to be the most, effective and efficacious GLP-1 drug that's going to come on the market. And then just at the end of this, I'm going to shut up in a second, but then we get to come back around to the idea of the national security issue of, at a high level, let's just think about this is the most efficacious treatment. GLP-1s are the most efficacious treatment for treating chronic disease. Chronic disease is where 80% of our healthcare expenditure goes. That's trillions of dollars. So, can the United States really afford to basically just sit on its hands and incinerate trillions of dollars? Or should we actually, as a country, say, you know what, we need to accelerate this as much as we can, and if that means embracing compounding, so be it. Eli Lilly is just going to have to get used to the being a $1 trillion company and not like a $5 trillion company, I guess.
By the way, Alex, you asked me, remember, in preparation to talk about Novo Nordisk versus Eli Lilly stock price. Sean just gave you the answer. Like, my number one answer was that retireotide, the market interprets, at least the interpretation of the market, it's a perceived monopoly, and stock market loves monopolies. So that's like the number one answer, Plus there are all other answers, but I think what Sean just said in terms of Eli Lilly being interpreted as monopoly, in that particular element, I think that explains a lot in terms of stock markets.
I want to add to what Sean said, because I am not here to defend a Lilly CEO by any means. I am not here to demonize them either, because I think some of their policies very much are still aligned with medical ethics. Prioritizing refills of medications over new starts is actually an ethical move, because we know that there's proven harm to losing access to a medication. We do not, technically, the company doesn't have the ethical burden, so to speak, to handle the individual who never is on a medication, right? So yes, Lilly does this in consultation with medical advisors. And yes, some of these maneuvers are certainly seen as business manipulation, stock market manipulations, and really just playing the game that our public health system has set up. And to your point, Sean, about national security, I think it would have been actually very smart of our government to have called in that Defense Act to say, oh, just like we had a COVID pandemic, we could have enlisted all of these manufacturers to make masks when there was a short of masks. We could have done that for GLP-1s, and that would have required a new level of regulation. And the difference there is really asking a new level of intervention and oversight that is pre-market, comparable to FDA-approved medications, rather than post-market. Right now, compounding exists in the same way that supplements exist, in the sense that enforcement is usually after a medication or a supplement has already been tried by several members of the public, after harm has already occurred, and then going retrospectively to see if there is an issue. Whereas with FDA-approved medications, pharmaceutical companies are under a number of different regulations to prove that safety before it hits the market. So that lack of parity, I think, it ties the hands of many pharmaceutical companies to decide where their investments are. And it speaks to some of their risk-taking too, having built multiple manufacturing plants for a medication like orforglipron even before that FDA approval, with the intention of making sure that they can meet clinical and patient demand. Yes, it's also a maneuver to avoid any shortages and any ways that people can get around 503A and we're using the 503A and 503B regulations to do compounding, but there's also a true patient care need that they're trying to meet. And so I'm not here to defend one or demonize another or what have you. I think, unfortunately, we work in a public health system that has allowed weight management and obesity to exist in outside of the medical space for so long. And it means that the public health system is not ready to expand that capacity and meet the demand of 100 million Americans who would qualify for these medications. And that's how everyone else is stepping in to try to fill that niche.
Yeah, I completely understand and don't disagree. I think that what's unique about the situation with GLP-1s and why I think that this is probably maybe a one-off in history is I don't think that this is an innovation we can actually lose. We need to have global parity with China and India. Otherwise, I think, in context of how does China, getting into the national security implication side of things a little bit, which is like geopolitics. But if China's looking to take advantage of the United States, my argument, the argument of other people is that they do it through the dollar, and they do it through, destabilizing the dollar. And so I think the scary macro level concept is, if we're 6 years behind, so generics are now live in China and India. So now officially, as of March of this year, generics are now in China and India and could scale, they are going to scale at a much higher rate than in the United States. So low-cost generics are not going to scale in the United States for at least 6 years. So I think that's where this national security issue really becomes obvious. Like we're sort of slow walking into a scenario where we're handing one country a 6-year head start on reducing chronic disease expenditure, which is trillions of dollars through the United States. We're going to hand a 6-year head start to China, and that will have impacts on the United States, on the dollar specifically, which, I think is like the actual threat that people, concern themselves with the most. I don't think anyone's really concerned about China launching, missiles at the United States or really wanting to harm the United States. I think there's more of a legitimate argument that, destabilize the dollar, make us more vulnerable in regard to trade. That's a longer term, more realistic, scenario. So I think that, GLP-1s are, I never thought that I would be involved in advocating for an injectable drug. If you had told me that 5 years ago, I would have said you were crazy. But the data speaks for itself. These drugs are so efficacious at reducing chronic disease expenditure. It's just we're at this point where it's like, this is the math. Like, this reduces chronic disease expenditure too efficiently to just ignore it and hand a 6-year head start to one perceived adversary. So I think that that's an important distinction for me, and I think that that's I wish that Novo and Lilly would go to every stakeholder on the large scale compounding side of the business and basically talk about licensing. That would be a solution to scaling up low cost access instead of being focused on litigating it to death, and or what are the ways that they're going to use patent greening to try to just protect a duopoly or protect their innovation. And one last thing in regard to the argument of, well, we invest all of this money into this system, and if not for this innovation that we spent so much on with Lilly's pill with orforglipron, they licensed that for $65 million in 2016. They didn't spend billions and billions and decades developing that drug. They licensed it, and then they, by their own admission, got it through this process for approval faster than they've ever done in the history of that company. So I think that there's a lot that can be said about intentions and patient safety, and whether that's coming second to just the business opportunity itself. And David Ricks has described orforglipron as the drug for scale. Those are his exact words. It's the drug for scale, and it's easy for them to manufacture. And Dave, I think you've expressed concerns recently. I think both of us, I believe, are the only people on LinkedIn that I know of who were like, hey, we might want to discuss the safety profile of this drug a little bit more than is going on right now.
Mm-hmm. Yeah, and I've taken a lot of flack for that. And I think, so for background, orforglipron is the first small molecule GLP-1 pill. So there was one GLP-1 pill before it, the Wegovy pill. It's semaglutide, and this is a peptide, right? And so orforglipron is the first non-peptide version, meaning your body can metabolize it. And there's bioavailability, right? So it's processed by your liver instead of the peptide, which requires a whole $2 billion technology for your stomach to sort of absorb the peptide in your body to utilize it. But I digress. So as Sean said, this was one of the fastest drug approvals in history, orforglipron, and there were some blips, some hiccups early on in phase 2 data that showed that there were some really high ALT, AST liver enzyme numbers, again, because this is the first GLP-1 that's metabolized by your liver. And so in response to the FDA, well, the FDA approved it, and then required on the back end some testing, which I understand is pretty normal for small molecule drugs, anything metabolized by the liver. However, Lilly's response immediately was to release their phase 3 data on diabetes. It's a 2-year study of the drug, and they said it's shipshape. It's been proven again in another trial to be completely safe. But we still don't have those charts of the 10x ALT, AST liver enzymes, and I'll be interested to see that. And so while it looks generally safe for patients, my concern, and I realize that for a company like Eli Lilly, just like you said earlier, Dr. Chang, the burden can't really fall on a pharmaceutical company for patients who haven't started a drug. I think it's probably the same here. I don't know that the burden of safety of a drug can be examined as to whether or not people will abuse it in the real world. But my real world concern is this: is I know how people use these peptides. When they stop working, they take more. And people generally aren't going to understand that the small molecule oral version has a different risk profile than do the peptides. I'm not saying it's better. I'm not saying it's worse, but it's different. And so I'm concerned about the real world application of orforglipron is probably the best way I can state it, because I just know that people in the real world will take more than they're prescribed. If it means the scale's going to go down tomorrow, they'll take 2 today. And so that's my concern with it. We saw in the phase 2 clinical trials of orforglipron, the highest dose was at 45 milligrams, I think. In phase 3, they moved it down to 36, which is confusing because now that it's on the market, the highest dose is 17.2. They had basically a capsule formulation in the trials, and now it's a tablet formulation. And so it's a bioequivalent, I guess, or however you would phrase it medically, to the 36 milligram. But anyways, I've just seen some things with it because I follow this very closely, and knowing how the community uses it, will use these, if they think they can squeeze a little bit more efficacy out of it, taking more. And that's my main concern with orforglipron.
I think we have time for one last question, and really want to ask it because it looks like we need to record another episode of this, and I'd like to talk a lot more about markets and how GLP-1s might impact companies like McDonald's, Coca-Cola. I do think Novo is still overpunished by markets with the stock price, and this is another interesting topic I'd like to discuss at some point. But I want to ask my last question for today, and I'll address to Dr. Chen first, but happy to hear your other thoughts as well. My main question is, me as a fairly young male, a little overweight, I'm not ashamed of it, but probably I'd like to lose. Sergey, stop it. I'd like to lose another 20 pounds, but I have a lot of stress in my life. I don't have time for sports. I do a lot of traveling. I need to spend time with my kid. I can come up with many, many excuses, but when I come to you, Dr. Chan, as a doctor, and I say, "Hey, I want to lose this weight," would you recommend me to get on GLP-1s, or you say, "No, get your shit together, go to the gym, or start running at 6 a.m. instead of watching late basketball game, and you'll be fine." So the last question of this podcast: are GLP-1s enabling people to avoid changing their lifestyles?
My approach to this is just very realistic. If you tell me that this is how you live your life, this is what you enjoy, these are your kids, this is what your wife tells you to do, or, there are certain non-negotiables there that cannot be changed at this moment. Just like the example of a patient earlier who had retired and then, kids are moved out, doesn't work anymore. Now he has more time to focus on himself. That's a different scenario. And so if you tell me that this is what my life is, we have to work with that. I'm not going to spend 3 months, 6 months, a year asking you to make all these changes that you haven't made before anyway. And perhaps you were just as motivated, and now you're even more motivated to make those changes. You're even more motivated to get this weight loss. But because of just real life restrictions, it's hard. I'm not going to make you deal with a disease of obesity or an increased risk of disease in the future just to quote unquote prove yourself that we need to be doing lifestyle changes beforehand. And all of our professional guidelines have now acknowledged this too now. Our 2013 guidelines had always said that patients should do a trial of lifestyle therapy for at least 3 months before offering medications. We have since removed that because we recognize, number one, that we should be offering these tools in parallel. When I meet with a new patient, if they're eligible for XYZ, I talk about XYZ, and then I give them a recommendation. But that XYZ could be lifestyle, could be medication, could be surgery, even though I know and they know that I am not a surgeon and I'm going to recommend medication, and that's kind of where we are. That's number one. And then number two, what we're finding a lot is that the behavioral changes happen downstream of the medication. When we use a medication to fix whatever that root cause might be, maybe it's cravings, it's stress eating, it's always feeling hungry, never feeling full. Once we change that, then people are realizing that it's a lot easier to implement all of the lifestyle changes, the healthy habits that they've always known. So many patients will tell me, I know how to eat. It's just a matter of doing it, and I can't seem to do it because my body craves the bagel in the morning. It's hard for me to eat a salad or yogurt or high protein, what have you. I crave that carbohydrate. And this isn't to demonize carbohydrates, but this is just something that a lot of my patients say. But once they're on a GLP-1 that cuts some of that hedonic relationship with food or cultural relationship with food, they get back to the roots of food is food. I get to now have the mental space to choose what I want to eat, as opposed to my body sending me these hormonal signals to ask me to eat one thing or something else that I don't think is healthy enough. And so we are finding that people are able to implement and successfully sustain those lifestyle changes after we start the medication. So Alex, I would be happy to see you as a patient. You let me know at any point in time, but this is a very, very common question, and I think it just needs to be individualized to each person.
Just get your ass out and exercise. Don't go to doctor. What's the problem?
Thanks, Dr. Shane, and thanks, Sergey, for your comment. Really appreciate it. Dave, Sean, any last second comments on this, or anything you want to share?
I would just say to Sergey's comment, I know he's being funny, but I think this is sort of like the prevailing thought about these medications within the broader public, is that if folks would just do the things that they needed to do, then they wouldn't need the medication. And I think the success of these medications is probably the number one indication that it's not as simple as people want to make it out to be. I think the misnomer about people living with obesity is that they haven't done those things. And I think one of the ways that I always explain what these drugs do, because a lot of people want to simplify, what does a GLP-1 do? And when I'm asked that question, I basically say this. GLP-1s help to level the metabolic playing field for patients. So if you've been struggling to lose weight your whole life, and you've put in that honest effort, and you feel like you've been white knuckling your whole life to get off your 10, 15 pounds, or maybe for somebody like me, 100 pounds, and you feel like you're constantly dieting, you're constantly, and you're just not seeing the results, know that there are likely underlying metabolic and hormonal reasons why that's happening. And these medications, we're just at the tip of the iceberg, I think, of understanding how we can support people with hormone analogs. But these are leveling the metabolic playing field and allowing a lot of people to finally control their weight so that they can focus on other health things. And I think that's the really exciting part of this, is that millions and millions of people are now looking at longevity. They're looking at, how can I live better? How can I show up better for the people I love? How can I show up better for my employer? Where we've been so myopically focused on getting a number on the scale down. It's going to be really exciting to see what society does, and sort of to Sean's point about, national security. It's going to be really amazing to see what America can do when we really tackle this problem of obesity and free up people's minds to focus on elements of their health that are more optimization focused, so that they can achieve their highest potential. And I think that's really the magic of these medications, is they're allowing so many people to do that. And for those who are, maybe slower responders to the current medication, I think that's what makes the future of this space very exciting too.
This is a perfect ending. Thank you, Dave. To be honest, I'm blown away that 12% of population in the US is on GLP-1s now, which is, I think, it's a big number, and it means this is definitely not fake, not illusion. It's something that helps people across the country and across the world. So I think our task is to continue doing this podcast, sharing more information, truthful information to potential patients or people who are already using that. And we'll definitely do at least a few more episodes on this for sure. But thank you so much, Sean, Dave, Beverly, Sergey, of course. You were the best, as always. But yeah, thank you so much, guys.